Sabine, hi, and thank you so much for joining me for a discussion on Faces of Digital Health, where we're going to discuss the state of healthcare and healthcare digitalization in India. You're a physician, you're a global health strategist with extensive experience leading digital health and public health initiatives in India. You also work as a UN strategist, and you're a founder of Enira Consulting, which bridges policy, technology, and clinical practice. So it's summer. What's currently keeping you busy? Just to start on an easier note.
Well, it's a rainy season here in India right now. It's beautiful. It's raining across, though the humidity does get a hold of you at times. What is keeping me busy is basically, this is the season where Southeast Asia actually sees a lot of surge in infectious diseases and the problems around that. So, resource structuring so that we have right pockets of vaccinations and testings like the dengue vaccine or the drugs around problems like cholera, which are more waterborne in the right pockets. That is one thing that's keeping me busy. Also, we are working hard on things like the over-the-counter bill and the data privacy within healthcare bill. So a lot of the policy work also keeps us busy on that
Mhm.
right now.
Since you mentioned, vaccinations and also communicable diseases, it's a topic that when it comes to developed countries, we don't often talk about because non-communicable diseases are at the forefront. So when it comes to, all the interventions that you need to do in India for communicable diseases, where are the biggest challenges? Are people, used to some precaution measurements that you are executing? Are there any reservations, for example, in terms of vaccines? How is that changing the culture and the attitude towards these interventions?
So, first of all, even in countries like India and any other, global south country, universally NCD, the non-communicable disease problem is the biggest. And whether it's infectious or not, I mean, you have to understand that at the end of the day, the mortality and the morbidity of the cohort of patients actually increases when you have underlying disorders, right? Which is non-communicable diseases, your diabetes, your anemia, your hypertensions of the world, your cardiovascular diseases of the world. So the more sick you already are, the more you're going to be affected by infectious diseases. That's a given. That's a no-brainer. So everyone is working hard on reducing non-communicable diseases, right? So are we. Though because we are a tropical country, and so are countries like Egypt, Tunisia, Morocco, and for that matter, Brazil and others. We do have large forest areas, even though they are not as large as they used to be, unfortunately, but there are still large forest areas. There are pockets where there could be mosquito infestations and mosquito-borne diseases or waterborne diseases can come in common just because the seasonal cycles shift differently in this part of the world. And because of that, there's a double whammy. We have to be more careful on that front as well. Now, India per se has been very vaccine forward. So we used to have these large vaccine drives for polio. We were one of the first people to eradicate polio from India. We have had large vaccine drives for many other things as well, which have been very successful. So, because of the polio vaccination, there has been a huge shift in education and approach towards vaccine, and it's been widely successful. So today in India, we hardly have a child which is not vaccinated. So
Hmm.
be it the BCG vaccine, which is uh, the bacillus vaccine, or for that matter elephantitis. A lot of these things have been almost completely eliminated because almost everyone is vaccinated at this point.
Hmm.
And even yeah.
I think it's important to just put that in context a little bit, just in terms of the size of the country. So before we continue, let's outline the landscape in India a little bit. It's the most populous country in the world. It has 1.4 billion people, even more than China. Just for the listeners or the viewers to have a bit of a perspective, 1.4 billion is 4 times as much as the population of the US. So it's really, really huge. So having that in perspective when we say that all children are vaccinated is definitely a huge success. So can you talk a little bit about the country from that perspective? What do you see are the misconceptions people might have about healthcare and digital health in India and the country itself?
So my opinions might be a little biased because I'm from here, I've studied here, I've worked across the world. So I'll give you a little bit of my thought points, right? One is India is 1.477 billion. So we actually are touching about 1.5 billion at this point,
Mm-hmm.
closer to that. That being said, fertility is also a concern now in India, this declining fertility rates, because we have dipped down to about 1.8, 1.9 actually, sorry, in many regions. So we are also declining instead of the 2.1, which is the maintenance rate of fertility globally. We are a little lower than that, unfortunately. Though we are a country of very young people, and the next 40 years are these people who are going to come into the economy, who are going to build the economy, and who are going to basically invest and become the driving forces both as consumers and as providers of captive work. I mean, in terms of population, we have one of the younger populations across the world. Of course, Africa is younger than we are, but in terms of education and access, we have far better. And Africa is a continent, it's a much, much bigger continent. We are a country. So the governance systems in Africa are 44 different ones, while in India, there's a single governance ecosystem. So we are not a federal state, we are actually a democratic republic, which means that a lot of decisions are taken centrally, and states, even though they have shared decision making, they still do adhere to central policies on a lot of things, which are like the disaster management, which we centralized and we looked at very deeply during COVID. So I think that is something that gives India a bit of an edge when it comes to how things are developing. One is it's a growing population, it's a very well English educated population. So one of the most numbers of English speakers across the world are Indians and in India. So there are more English speakers in India than anywhere in the world today.
Mm-hmm.
So a lot of access to tech, a lot of access to app systems become much easier because we don't have the language barrier in that sense.
Yeah.
Plus, for that matter, as I said, education is coming in very handy. Digital payment systems have spread out like it's nobody's business. So you can travel the length and breadth of India without carrying a credit card or carrying a card or carrying any cash whatsoever. You just need your phone, right? And you need a UPI connection. It's Universal Payments uh, Portal of India. So because of this, even in the smallest shop or a small cafe or a small shop, everything is digitally integrated at the moment. Even, this is something which is very strange. People think there are beggars in India. In India today, beggars actually beg with digital platform, saying, if
Mm-hmm.
you don't have cash, why don't you put some money on my Paytm account?
Mm-hmm.
Which is sad, but which is also pretty fascinating if you think about it, that people have smartphones. There is a saturation of smartphones by almost 97% in the urban region, and it is closer to 79% in the rural region. And almost every one of them is digital payments enabled. So that platform has matured so well that building on top of it, different digital ecosystems has become much simpler and easier.
Mm-hmm.
Secondly, uh, there is a huge, huge push, I think. So, if you really look at it, Indian doctors have always been celebrated across the world. Even uh, though the Indian doctors have not stayed much in India in the last 2 decades or so, they have had a lot of brain drain in that matter. but still the doctors have been educated in India because the sheer volume of patients that the doctors do get to treat in the early stages of their career makes their skill and their diagnosing capabilities, or rather the way they approach medical science and cases, very, very astute. And I think that is why, if you really look into it, if you look at the Middle Eastern region, the GCC, or even in the US, a lot of massive health ecosystems are led by doctors who had early education in India, which is then early medical education. And then they, of course, learned a lot of other processes outside. So the system is not as process driven as it's in the US, or definitely not. We don't really have universal health coverage yet, but we have a very thriving balance between the public and the private sector. Today, the private sector caters to almost 20% of global medical tourism across the world, both elective and non elective. So, emergency surgeries as well as otherwise, because the cost of care is still bearable. Though there is medical inflation that's almost at 14% right now, there is out of pocket expenditure that's high. That being said, the actual quality of healthcare delivery is really, really good. So, be it in the government space, which is the open to all public, or in the private space, which is a little more costly, but it's not still affordable. There is a lot of, compared to any other country in the northern part of the world, there is far more access to health delivery. One of the things that we also did well early on in the last 50 odd years was building a network of frontline workers, right? So we have closer to about 1.8 million frontline workers, all women who go home to home to do screenings, go home to do vaccinations, mother and child care, and also nutrition, which is how we brought down PEM, protein energy malnutrition, maternal mortality. Polio drives were run through this network of frontline workers, which are, again, as I said, all women within the rural and the urban space. So these are some of the things that we did right. There are, of course, a lot of things that still need to be done, but these are things that went very well. And now we are adding up layers of digital integration. So if you look at something called eSanjeevani is world's largest telemedicine platform run by the government of India. They actually do more than 15 million consultations every month. 15 million consultations every month. Until date, they would have done more than 300 million consultations.
Yeah.
So these are all free of cost.
Mhm.
So you just need an app and you will have a doctor available. Now, as I said again, because there have been doctors who have left the country to study and work abroad, that is in the last 20 odd years, that has been our challenge in getting more doctors into the system, or more healthcare workers into the organized healthcare space. So that is certainly a challenge that we are dealing with.
Yeah.
Also, digital architecture is not mandatory yet. So it is still a good to have, but not a need to have. So there is no policy framework that says that you have to be digital. It's more market forces that are playing. So that is why there are still a lot of people within the organized space of healthcare, like hospitals, clinics, diagnostic chains, but people who also do unorganized business on the side. So they take cash payments, and payment cycles are not very regulated because insurance coverage is less than 7% in the country, private sector insurance. So basically, the due diligence on the payment cycle is not that great,
Hmm.
of course, and it's a little fragmented. So adoption of digital systems is not as much. Though the number of players, as in, you will find more than 10,000 hospital information systems in the country. So they compete very hard with each other. India is still the pharma center of the world. So we have a lot of pharmas who sponsor HIS systems for hospitals and clinics. So
Hmm.
adoption is growing fast, though we still have a way to go.
So many questions to touch
Sorry.
upon there. We'll talk about those 10,000 healthcare information systems, because I really want to know what that means for interoperability, especially since in the last few years India has been heavily developing the individual personal identifier and the connected patient portal and infrastructure to support that. But if we go back to accessibility accessibility and affordability of healthcare, which you mentioned. Can you talk a little bit more about that? So a few years ago, India started developing this national health protection scheme, a special insurance also for the poor population. One of the Indian thought leaders, Devi Shetty, also likes to say that India will be the first country that will separate health and wealth. So what do you think about that? Data also says that 70% of people live in rural areas, but only 1/3 of doctors live there. So how do all these numbers go together? How well is the infrastructure? How well can digitalization actually support health outcomes even in remote areas?
So let's break this down first, okay? One is, let's talk about access. So in India, we have the largest saturation of pharmacies or pharmaceutical outlets in the world, right?
Mm-hmm.
Per capita. So access to medicine, though you might hear harrowing stories that you had to cross a river to go and get medication, it's not true today. You can get medication very easily because there are lots of pharmacies, small pharmaceutical outlets in even in the remotest part of the country. That is one. That being said, it is not the same for diagnostics and doctors. So diagnostics need a much larger setup, be it biochemical, be it IVD, or be it radiological. All of them need more capital investment and need larger setup. So unfortunately, though medicines are available, the process to get them is a little broken. So people do have access to medication, but how? They just go to the pharmacist and say that I am feeling a slight itch in my throat, or I'm feeling a headache or a fever coming on, and the pharmacist just gives them medication. There's no prescription, there's no billing, is just an on cash payment. Unfortunately, this has led to quite a few secondary problems, um, which has resulted in excessive steroid use because steroids make you feel better very quickly. So people think the pharmacist is good. This has also resulted, now that is one. So there need to be a lot more investment in creating a diagnostic infrastructure, and even more so in point of care aided solutions. So we already have a network of frontline workers, right? If we can possibly empower them by giving them digital devices like a glucometer, like a BP, digital BP machine, and a bundle of those, then they actually can act as mobile diagnostic centers, at least for some primary testing, right?
Mm-hmm.
And that is a approach that is starting to get taken now, where there are government programs as well as private companies who are building those ecosystems of frontline workers with devices who can act as a mobile diagnostic system. Secondly, the access to doctors is certainly limited because, as I said, the number of doctors per capita is certainly less, and even more so in rural spaces than urban. You have to understand that this is a very deep rooted problem because of that. Because when even a person from a rural family gets access to medical education, they find that as a ticket to go to the cities, as ticket to get developed and go to the cities. And to be very honest, the surprising thing is because of the demand and supply thing, the number of the actual money that you get as a doctor in the city is much lesser than the money you get as a doctor in the rural areas, even with lesser credentials. So you can be a graduate doctor, an MD physician, and your or an MBBS as we call it in India, your MD physician is a secondary education year. But you can just be a medical graduate and you will get paid 4 times what you would get paid in a city being a specialized doctor. But still, just for access to better education, access to a better lifestyle, a Veblen lifestyle, brands, the whole Instagram culture is populating very quickly. So just because of that, doctors still choose to be more in the cities than in the rural spaces. Now, actually, the aggregation of doctors in cities is severe, which is why doctors are not able to make a lot of money. Because not only are there a lot of single practitioners and clinics and nursing homes, but also large hospitals, all of them in the same metropolitan regions, which constitute about 30%, 35% of the population. So that is the massive divide that we see in terms of specialty education. So what happens now in rural areas is people who have had some access to healthcare ecosystem, like say, for example, a nurse who has practiced with a doctor for about 15 years, or a ward boy who has done that, he will come back to his village, open a clinic, and people will go to him because he at least has some functional knowledge without any credentials, but functional knowledge. Now, those are called quakes in India. They actually are the backbone right now of the rural health ecosystem,
Mm-hmm.
unfortunately, because try as the government may, doctors haven't been present in the rural ecosystem for a while,
Mm-hmm.
even though there had been mandatory regulations and everything around it. So, in this case, digital platform comes in very handy. So, as I said, that there is access to drugs, there is lesser access to diagnostics, there's almost no access to doctors. Now, there, at least for primary diagnosis, like for example, you are aging and you have pain in your knees. Now, of course, you know what to do, right? You have to look at some basics, like you have to look at the calcium levels in the person. You have to see if there is depreciation in bones, overall activity. We know the normal diet of the region is low in calcium and also low in protein. So we have to prescribe proteins and calcium to top that up. And of course, with age, if that person is menopausal, so if it's a woman and is menopausal, then we have to have some little bit more extra care in that case because calcium leaching becomes a problem. So those kind of things are more instinctual for a doctor or a clinician. Then it becomes a process driven mechanism. So we don't have enough doctors right now who can run strategic processes, which is a gap that is being felt strongly in the rural region, which is why the digital ecosystems are coming to play in a big way. So CDS systems that reduce the time per patient for a doctor, a clinical decision support system, for example, or for that matter, uh, you know, digital platforms that increase the reach of a doctor. So they don't have to physically go to the rural centers except if there's an emergency, but they can, basically do basic OPDs with the patient while sitting in their homes or their clinics in the cities. That serves a purpose for both the lifestyle purpose for the doctors as well as for the rural patients. So the digital transformation in these two spaces is playing a big part also. Slowly and steadily, the insurance play is growing. So, what Dr. Devi Shetty, and he is my senior from college actually, has built now is an integrated system which is not unlike Kaiser. But in my humble opinion, what I feel is that the real estate component of healthcare is one thing that we still need to be wary about because you can never build enough hospitals, you can never have enough doctors. So the only way you can process access to healthcare and affordability is by making or keeping people healthy. And for doing that, for a rural population which may not be able to afford large scale gym memberships or dietitian consultations, and even if they do, they don't have money to buy high grade food products which might not be locally available for them. So for that, healthcare interventions need to be a little more minimalistic and still create the integrated effect. So India has also started giving out more healthcare licenses. Policies are shifting in that. Health insurance licenses, my apologies. So policies are shifting around that as well. And we hope that in the next 10 years, we'll see far more private sector players entering into the insurance play, which also regulates, um, the level of little bit of chaos that we have in the healthcare ecosystem. So drugs will not be prescribed as easily, which is a good thing because AMR is becoming a secondary problem, as I said, and steroid use is resulting in CKD, chronic kidney disease, and other things. Sorry, I hope I'm not speaking too fast.
No, you're good. You sped up a little bit. So,
Sorry.
but you know this, so you're very self-aware.
Yeah. No, no. So I think that is the kind of things that we are talking about. And this is, you know, which is why there is a lot of digitization happening now. You also spoke about ABHA. ABHA is the
Yeah.
digital health ID of India.
Let's before we jump into that, I just have a question that got me thinking. It's a bit of a provocative one, and I guess one that we don't often think about. But we know that the shortage of clinicians is rising. We know that we're not going to train as many doctors as we need. So based on, everything that you said, based on the high number of frontline workers, and especially with the advent of generative AI and AI in general, do you think that we're thinking in the wrong direction by just focusing on the shortage of doctors, the shortage of doctors? So how do you see, that, and basically the potential impact that AI could have in redefining the roles of different healthcare workers and improving health of the population to prevent complications?
That we need to keep people healthy, right? We need to keep a larger population healthy. Now, when we talk about public health and preventive health as a whole, we are talking about what are we trying to prevent? You can give me an answer. What are we really trying to prevent?
Complications, high costs, overload of the system.
Yeah, we are trying to prevent an acute health crisis, right? We can manage chronic solutions and chronic problems, and we do try to. Prevention is not about preventing diseases today, because if I want to say prevent diabetes, it's going to be very difficult. If I want to reverse diabetes, I will have to inject beta Langerhans cells with PRP probably. And I don't know if that would work even. But so we cannot clinically reverse diseases or clinically prevent them. What we can do is prevent acute health events, which might result in economic burdens as well as surgical and systemic burdens. So when I can go home to home, do recurrent screening, do baseline management with the network of frontline health workers that we are talking about, then at that point, we would be able to risk reduce the patients at a scale. But we need to do the minimum possible. So you are wearing an Aura ring right now, right? If I'm not mistaken.
It's not Aura Barea, it's a smart ring. You're
Yeah,
right.
smart ring. So, these rings are costly. To make them as costlier for for a country like India is, or the global south countries, to manufacture and to basically use this at scale is going to be very difficult. It is only going to be a solution affordable and truly accessible to, say, the top 5 or 10% of the population, and nothing more than that. So then how does it work out if that's the case? If that's the case, then what you need to do is what's the minimum possible necessary, because continuous monitoring systems are not going to work. They are an overkill, right? You don't need to measure everything at all times. You just need to know that you are in a broad span area of good health, which is, basic RBS once every couple of weeks or months, HbA1c maybe, and also serum HB, basic liver and kidney function, basic lipid profile. And now we are developing rapid tests for almost all of these at scale with really high scale accuracy, which can be done in the field in the hottest of temperatures in rain and humidity, and are still fairly accurate. So, we have large scale Indian companies like Mitra, like Medlera, like Accurex, so many other homegrown companies that are giving companies like Roche and companies like Thermo Fisher run for their money, because their manufacturing is in India is far cost effective. So at scale, this is the new innovation that is coming up. So we can do only the testings that are necessary at regular intervals and make sure that the person is still within the ambit of good health. This reduces burden both economically and otherwise. I think Gen AI is going to play a huge role in B2B spaces, right? In training and aiding frontline workers or training and aiding health workers. So CDSS is a form of Gen AI solutions. Our agentic systems are going to play a huge role in speeding up some of these processes. But as I said, health, and this is what I truly believe, that health is a very human-centric thing, right? When imagine if you are missing on a flight, right? You are going to be late for a flight and you call the airport or the airline and you get an automated answer. Would you be happy about that? You are agitated already. You would want a human voice on the other end because you know that a human might be able to help you. And even if they won't, just listening to a human calm you down will actually affect your dopamine levels, your serotonin levels drastically versus reading the same information or hearing the same information from an automated system. So, health, when I touch a patient, when I hold their hand and say, you're going to be fine, and I'm here with you irrespective, that changes their behavior, and the adoption to health advice and health ecosystems is far greater when you have a human component touching it, right? So, and the global south has an abundance of humans. So, that is the interface that I don't think we need to change anytime soon because it is
Hmm.
really playing out in the community effect that we have in adoption of healthcare. So the other day there was the hepatitis day celebration, hepatitis B day celebration, and I had about 50 odd patients on my screen talking about their personal STI problems, that's sexually transmitted infection problems, without any shame. They knew all of them were there and they were talking about this because health is a community approach in some of these societies which have been built on a community effect. It's not about an individual or the care, or rather the onus of care being shifted on a single person, because it's not you who is to blame, or there is no blame game. There is a effect of neighborhoods, of communities playing out, and that is a very beautiful thing to see. That
Hmm.
is how you build good health.
Absolutely. Support rather than stigma.
Yeah.
So the thing that I wanted to ask, since you mentioned rapid testing and development of it for all temperatures and climate conditions, are there any innovations that you see in India that are potentially worth mentioning and are not as well known more broadly, or anything that you see as a really big milestone in terms of helping healthcare?
See, I think a lot has been happening. There are smaller companies like Vidcare that is doing amazing. As I said, I mentioned a few already that are doing great. I still think India has a little bit way to go in developing novel technologies in diagnostics, but India is a foreground in adoption of diagnostic technologies, right? So we are adopting technologies from across the world, from Korea, from Israel, from Russia, which is all coming together to build an integrated health ecosystem. And there are companies in the early stages that are developing good diagnostic systems, diagnostic technologies, but I would hold back before mentioning anything which is groundbreaking today because a lot of these are in early stages of validation. And I
Hmm.
would want to see how they validate across global standards before we mention about them. But there is a lot of interesting approach, right? There are and one thing I would love to mention is a company that was born out of Bombay. They moved to Singapore a few years ago, which is not something I'm happy about, but it's called ZAR Labs. Now they are fundamentally shifting the way cancer diagnosis can happen across all value chains. So they are able to do spot diagnosis of cancer from pre-embryonic stem cells that they discovered in the buffy coat of a centrifuge blood sample. So you can just take a blood sample for about $10 and you can get to know if you have cancer across any part of your body. And this includes both solid state tumors as well as blood cancer. This is this is mind-boggling.
Mm.
$10 that we are talking about, right?
Yeah,
So
very affordable. I
yeah.
mean, compared to the diagnostics that you can see and the prices that you can see potentially in the West.
Yeah, so this is the kind of things that can scale and reduce, and scale and reduce large scale complications for the masses.
Mm-hmm.
Because in a place where we have oral cancer and lung cancer becoming prevalent, or cervical cancer becoming prevalent, it's very difficult to do cervical screening because you still have to put women in a lithotomy position. Even with self-screening, it's not that accurate today. But if you can take a blood sample and give a person a test of whether they have any cancer or not right now, then I can do that blood test once every year and
Yeah,
know any early onset that's happening.
yeah, yeah, yeah.
I
There's
think Zajc is
definitely,
phenomenal. I was completely gaga about that. I really hope
yeah,
go
yeah,
ahead.
yeah, yeah. There's a lot of hope in liquid biopsies and the
No,
development of.
this is not liquid biopsy. This
Uh-huh.
is pre-embryonic stem cells. So liquid biopsy actually looks at biomarkers, tumor markers. This basically looks at pre-embryonic stem cells, which are precursors to tumor formation. So
Mm-hmm.
presence of their numbers, which is very, very small. So they figured out a way to basically culture that from the buffet code, and then of course diagnose them. So the point is, this is much before there is any tumor formation. So liquid biopsies only functional once there is a tumor, and they only
Right.
work for tumor markers. They don't work for liquid cancers, so
Mm-hmm.
blood cancers.
Okay. Yeah, yeah. So it's like a step even
Hmm.
before.
Much
Yeah,
before.
yeah,
This is
yeah.
before there is when there are just basic tumor cells which are undiagnosable even by a PET scan.
Mm-hmm. That sounds very optimistic. Um,
Yes.
if we go a little bit back to the healthcare system of India and the approach to manage the health of such a large population, we mentioned a few times that a personal health identifier was introduced in 2021. There was a telemedicine platform in 2019. Initially as a way for clinicians to consult each other, but then as COVID hit, it was expanded for patient to doctor consultations. Where is, the whole personal health identifier project today? What are the results of that? How is that advancing? Do you already see any benefits of that approach?
So see, India has two IDs today, primarily. One is actually we have three, four, but two are more important. Yes, I'll talk about them. One is ABHA. Okay, ABHA is the Ayushman Bharat Health Address, which is the personal health identifier as you are talking about. This health address in a wallet system stores all your health data, current and going forward. Unfortunately, we don't have a lot of historical data. The way they started integrating patients are creating, you know, easy pathways to gain admissions or gain appointments within the government health ecosystem. So they started with a low and medium income strata of the population. Today, more than 60% of the population has a current health address, and more than 40% of those are using it on a regular basis. The problem with the health address right now is that the adoption on the provider side, like the hospitals, the diagnostic chains, the pharmacies, is still limited. Hospitals are coming on board, yes, but individual doctors, pharmacies, nursing homes, diagnostic chains are not coming on board yet. So corporate adoption is there, but private individual adoption is low because there is a lot of barrier and thought processes around what it will do to billing systems, how it will integrate into business in general, what will taxation look like if that happens, because this was an all cash sector for a while. People didn't pay a lot of taxes, so people are afraid now they will become taxable in nature. So those are the kind, and pharmacies are not well monitored today. So there is not a lot of difference. Today, if I want to order any drug, I can just call up a pharmacy and they'll deliver it to my office, which is without any prescription. And unfortunately, they are scared that that entire system will go away. It should go away, but that is the fear and the barrier at the provider side, which is why the adoption is a little slow because it's not mandated. It is a good to have, as I mentioned earlier, but not a need to have on the provider side at the moment. But
Mm-hmm.
as more people are coming on board, it's the people who are asking for the same to integrate with the ABHA ID, and also the insurer players, because they are much bigger and corporate in nature, they have already adopted it at scale. So it's going as a top-down approach. More and more people who need referrals will need ABHA ID. So people who are referring to higher hospitals will eventually have to get an ABHA ID. So I think
Mm-hmm.
that is essentially one way to go about it. The second way that they are doing validation of identification is through Aadhaar. Aadhaar is the unique identifier for all other government portals. So these two IDs are closely connected with each other, and they basically shuffle the consent and the identifier information, which is a very interesting backend stack that is being developed by the government. So the Aadhaar was the base of UPI, and now Aadhaar has also become the base for ABHA.
Mm-hmm. Is it any indications that, the health identifier would be mandatory for healthcare providers?
No, I think it's, as I said, India is a democratic republic. They will not push it, but they will cajole people to do it. And then
Mm-hmm.
it's the market forces that act out, right? As I said, uh, if today I'm a very small clinician or I have a small clinic somewhere, but the doctor or the hospital that I'm referring my patient to mandates it for me, then I will obviously adopt it at some point, right? So I might be a little scared, but if the hospital that I need to refer my patient to, it's a business case, they mandate it, then I will have to use it.
Mm-hmm.
So I think it's going to be slightly top down in that nature, but it's happening. It's happening quickly.
Mm-hmm. We mentioned earlier that you said that there's 10,000 healthcare IT providers or healthcare IT systems in the country, which is huge. And
I think 10,000 is an underballing number because there are new ones coming up every day.
how do they communicate among each other? Some IT experts, especially, for example, for the NHS, say that the fact that they have the personal health identifier, it makes things vastly easier when it comes to, connecting different data. So what's the state of interoperability?
That is exactly the point. Interoperability is much easier. It's never been that big of a problem because India has always acted from a patient-facing approach. So they don't care about sharing the data. Or today, if I want to get my patient file in a hospital, it's extremely easy. I just have to ask for it, and within seconds, I'll get my patient file and the physical file. On the other hand, ABHA is instantaneous. It won't even take seconds. So the hospital will anyway upload the records, and I, as a patient, will have access to it. So it's a patient-centric ecosystem that is built, right? So today, I, as a patient, have all my records, and I have all the right to take it to any provider that I want to. Right. And they will also integrate the data into the same digital address. So the providers don't even have to talk to each other if they don't want to, but because they're all on the same universal health address, because of that, the talking to each other becomes an automatic process. Also, there are health claims systems which are universal and have a government architecture like health claims exchange platforms. So where different insurance providers also share information so that there's no excessive billing within providers or overselling of healthcare, which is a little difficult to manage sometimes.
Mm-hmm.
So as you said, the approach is slightly different. It's the patient who is the owner of the health record, right?
Mm-hmm.
No hospital, no clinic can gatekeep the record because it's automatically transferred to the patient. And the patient can sue the hospital if they do not give the record right away to you, even in an
Mm-hmm.
ICU.
Mm-hmm.
And this is taken very, very seriously.
Does it happen that the patients would actually file suits towards
They
healthcare
can,
institutions?
they do. The legal systems are a little difficult, but the PR, the public, uh, outrage around it plays out far more quickly and violently sometimes, unfortunately. There have
Mm,
been instances where hospital owners have been beaten up by a mob if they don't share records, or, doctors have been. So, and that's not a fair way to do it, of course. Our court systems are a little lagging at the moment, and a lot of technology adoption needs to happen over there. But that being said, as I said, the knowledge that the patient record lies with the patient is very strong, even within the population. So no doctor will even dare to say no to give you your records or healthcare system, however big it is. They can deny. There are other things that they can stop doing. They cannot do. It's difficult to get appointments sometimes to very celebrated doctors because just the supply and demand thing, or some very corporate hospitals are very costly as well, especially for electives. If you are doing out of pocket, they can deny insurance. Is not mandated to take insurance systems. So there are certain things that can happen in lack of access, but information is definitely not a place where there is a gatekeeping happening.
Mm-hmm. Sabine, thank you so much for sharing all the insights and just creating this huge outline and understanding of the ecosystem in India. As the final question, where do you see the biggest opportunities in digital health in India? How do you hope that healthcare is going to advance with the help of technology?
Yeah, I think two areas where there is a large gap that needs to be, actually three areas where large gap needs to be met. One is the areas of diagnostics, where we need a lot more research, and we need to also look at Gen AI playing out in large scale population studies and research in genetic mapping of diseases, rare disease symptoms, which are specific to the continent, because we are talking about what, 1/5 of the world's population lying in a single region, right? So we do need to have medication which is a little more personalized for the region, a little more tailored, and understandings of problems that are a little more tailored both on diagnostics and pharmaceutical side. So a lot of technology needs to go and investment needs to go there, and that will result in good diagnostic and treatment modules which are tailored for the region. Secondly, because most clinical trials don't even have Indian population within them, that is a massive problem. So one place where there needs to be a huge level of investment, and in health IT is going to be invested in clinical research areas as well as in both in early and late stage. Second is diagnostics and large scale training systems for frontline ecosystems that are being developed not just in India but across. And the third is insurance. I think insurance is going to be a key player in fostering innovation within the health IT ecosystem. And I mean, we need to think a little outside the box. It's not just about hospitals and diagnostic chains and doctors anymore. It's about everyone else. And I think these are the three players that are going to be pivotal in adoption of health IT systems and also solving the problem of access, affordability, and accuracy of care delivery, which can
Mm-hmm.
have positive health outcome for a population, for a large scale population.
Mm. Sabine, thank you again. This was very, very insightful. So I definitely expect that we'll speak again in the future. But thank you so much for all the insights today.
So much for having me. Thank you.